So I'm going to talk a little bit about an algorithm to demystify, if you will, ulnar wrist pain. And of course, this is always considered to be kind of a black box, I guess, in the wrist. But I think it's really pretty simple to approach. It's just like anything. And as Dick mentioned, if you have some basic understanding of the anatomy, it helps quite a bit. So the basis of the algorithm, there are three things really: the history, the physical examination, and imaging. So that's the same as in anything, right? So the history is the most important, and you need to listen to the patient and find out when it started, how did it start, was there any history of trauma, did it come on suddenly, gradually, is it intermittent or constant, is it gradually getting worse, what makes it worse, activities wise or movements. And physical examination is really pretty simple in a sense, because you're really palpating to see what areas might be tender or warm, or you could look to see what areas are swollen. And then you're going to do some provocative maneuvers, which if everybody can see me, they're basically kind of just doing something back and forth like this. Just depends on where you're doing it, whether you're taking the distal ulna and trying to move it against the distal radius, or you're taking the lunate and doing this against the triquetrum, or whether you're taking the pisiform and moving it against the triquetrum. So that's really pretty simple as far as the physical examination test that you do. And then there's imaging, of course, X-ray, CT, MR, and I'll leave Jeff to talk about the ultrasound. So applying the algorithm, use history, as I mentioned before, as the first screen. Because this will help you to focus your examination then. And I've already mentioned some of the things you look for. And then use the examination to try to localize more specifically. So is the tenderness over the lunate and triquetrum, is it slightly more proximal than that over the triangular fibrocartilage? Is it slightly more proximal than that over the distal radial ulnar joint? Or if you go on to the ulnar side of the wrist, is it in the pisiform area? Is it just proximal to there in the fovea, the ulnar snuff box, if you will? Or is it proximal and a little bit dorsal to that over the extensor carpi ulnaris? So again, you're just kind of marching a little bit from distal to proximal on the dorsal aspect of the wrist and on the ulnar side of the wrist, and to some extent on the palmar side for the pisiform. And then you use your imaging to confirm your clinical suspicions and to assess severity, because that's one thing you can't really do on your physical examination, is to know how much cartilage loss there is, how much joint narrowing there is, and you certainly can't easily quantify how much instability there is. So the rest of this talk is I'm just going to give you some examples. Then we'll do some tendon, ligament, and then some bony examples. And I'm not going to talk about treatment because that's what some of the other talks are for. So extensor carpi ulnaris, as you know, the tendon can become either inflamed or it can subluxate out of its subsheath, and there are various classifications for that. You can see it on imaging. History is typically of a traumatic episode. Sudden, like a golf swing, is something we typically see here in the U.S., for example, but any other kind of twisting trauma. Examination will show that there's tenderness, and sometimes you'll see swelling over the extensor carpi ulnaris. If the patient supinates and ulnarly deviates their wrist, you can feel the tendon frequently snap, and you can confirm the diagnosis either by ultrasound or MR imaging typically. Distal radial ulnar joint instability. Dick Berger has created this really nice way to quantify the actual amount of subluxation, as you can see here in passive and resisted, pronation, supination, and in the neutral position. So you can actually get some good quantification of how unstable is the distal radial ulnar joint. But I've found that on clinical examination, you can actually have the patient hold their wrist in the neutral position and see if the radius and ulna are unstable next to each other. In supination, frequently it's more stable in that position, or in pronation, which is that piano key sign. So you can actually, on physical examination, also get a rough estimate of if the distal radial ulnar joint is stable or unstable. And I've already mentioned that you can palpate the tenderness in the joint. And then imaging, as I've already suggested here, CT scan is probably the best way to quantify distal radial ulnar joint instability. A ulnar triquetral split tear, which Dick described classically as a very severe tenderness in this ulnar snuff box or fovea. So that's probably the classic physical examination. And again, it's a kind of a twisting wrist motion aggravation, usually associated with with a specific injury, although sometimes it can be more indolent. And MR imaging and arthroscopic imaging would be the best ways to see that. TFCC tear without instability. Now you can say, well, on this MRI, well, maybe that probably does have some instability because this foveal area has been damaged, but just the point of using an MR for imaging. But typically, this will be a degenerative problem with a gradual onset, tenderness over the triangular fibrocartilage, and there'll be pain frequently. You can compress the carpus against the ulna, and you can translate, I can't do it very easily on my own wrist, but you can translate the ulnar side of the carpus dorsally and palmarly on the distal ulna, and frequently with some compression, and frequently that'll cause pain. It also causes pain with ulnocarpal impaction. And so that's the, and then imaging MR is usually good for triangular fibrocartilage, just like other soft tissue. LT dissociation frequently is traumatic. Again, there'll be tenderness over the lunotriquetral joint. You can ballot, translate the lunate against the triquetrum and feel for instability and see how much pain that might cause. And of course, one thing you also have to do on the x-rays, you can see a loss of Galula's lines. Of course, one thing you have to do when you are looking for lunotriquetral dissociation is just make sure you're not really dealing with ulnocarpal impaction syndrome, because the ulnocarpal impaction can frequently cause pain right in that same area. So obviously you'd need x-rays to assess that aspect. DRUJ arthritis, gradual onset is because it's a degenerative problem, tenderness over the joint, pain and crepitus with pronation and supination, and x-rays are usually sufficient to make that diagnosis. And then ulnocarpal impaction, I've already mentioned a couple times. Typically, it's a gradual onset, tenderness without instability, pretty much in the same place as the triangular fibrocartilage. And so imaging is really going to have to sort out ulnocarpal impaction from lunotriquetral instability or some problem with the distal radial ulnar joint. And so frequently MR is good because you can see the edema in the bone, but x-rays will also be good for that. And then pisotriquetral arthritis typically is going to be tenderness over the pisiform. You can move it back and forth. It'll be crepitant. You can feel some swelling there, some warmth, and some pain. And you can either use x-rays or CT or MR to image that. One big thing is to beware of overdiagnosis. And this is why I said you should start with the history first, then the physical examination to narrow it down, and then finally imaging to narrow it down and quantify and specify. Because if you start with imaging, you're going to find that there are way more lesions that you can find on imaging than you'll have symptoms. And so if you start at the wrong end, you're going to get yourself into a gigantic confusion. So start with the history, listen to the patient, use that to focus your examination, and then use that to select what imaging is going to be best to sort things out. And it may be more than one kind of imaging. And because if you start at the other end with the imaging, as I said, you're going to find that there are things on the radial side of the wrist, the dorsum, palmar, all over, and you'll just get confused. So that's pretty much it. And so hopefully that's a little bit of a whirlwind, but hopefully that'll kind of tee things up. And I hope that that's been helpful in giving a basic framework to look at evaluation of the ulnar side of the wrist. I'll stop sharing.